And I'd like to thank the organizers for doing this webcast live. It's actually the first time my children back in the US can watch me live, and not all content is appropriate for them, so I trust my husband to turn it off when he needs to. But acute HIV infection is a short but a critical period during the first 6 weeks of infection that is dynamic and sets the stage for long-term outcome. So we have a tremendous opportunity to learn from acute HIV infection research to inform prevention and treatment. And here are the viral load graphs from the RV217 study that was done in Pattaya several years ago. You can see that from the time of the last negative viral load, and this was followed prospectively, to the first viral load that was detected at around 100 copies, then we see the viral load rising very fast, reaching peak at about 14 days. And the viral load at that time is very high, up to 100 million copies per mil. And then the viral load declines rapidly, reaching a set point at about 42 days. So the virus that we can sequence during this period is called the transmitted founder virus. This is because it is the closest to the virus that made it through the mucosa to cause infection. So it can tell us a lot about the virus that is being transmitted in the community. I'd like to share with you what we have learned in our study, the SEARCH-10 study that was done at the Thai Red Cross AIDS Research Center in collaboration with AFRIMS and the US military and many other organizations. We can learn in terms of prevention, and I'll talk about how early diagnosis and treatment limits transmission, characterizing the transmitted founder virus, and informing difficult diagnosis, such as in people who are on PrEP or PEP. And in care, I'll talk about implementing immediate ART, characterizing treatment outcome, and mapping what are still irreversible events even after very early ART. So I do hope that this will be useful knowledge and information for your work, and I look forward to your comments at the end. The SEARCH-10 study started in 2009, and it has been an amazing team work at the Thai Red Cross and among the collaborators. We leverage the Thai Red Cross Anonymous Clinic, that is the largest HIV testing center in Thailand, to screen for acute infection. Over the past almost 10 years, we've screened over 300,000 samples and have enrolled and treated more than 500 people in acute infection. And the majority of our participants are young MSM who gives a history of being exposed to HIV in the past 3 weeks. The way we screen, we start off in the clinic with the 4th generation antigen-antibody combo assay, and then we institute research testing, which is a less sensitive immunoassay, and pool nucleic acid testing. So you can see that in the people who are reactive to all of the tests, they're generally, we call them chronically infected, but there are people who are still non-reactive to the less sensitive test, and so they have not yet developed IgG to HIV, and so they are still in the acute HIV infection period. Now on the right are the people who are either negative, so uninfected, or they have positive nucleic acid test, and so they are in the very early stages of acute infection. So you might ask, what if I don't have acute HIV infection screen in my setting? So there are some clues that could help you. One is that acute retroviral syndrome is very common. So here we see people with fever, sore throat, myalgia, lymphadenopathy, diarrhea. So that could be a clue to test for HIV. When you see discrepancy between the first test and the confirmed test, then that also is a suggestion that maybe people are in recent infection. And if you really, really suspect someone could have HIV, here I would do nucleic acid testing or viral load, and that could help diagnose people in early acutes. Now, if we miss acute infection, we miss an opportunity to limit transmission. And so the acute HIV infection period is a time when there's such a high chance of transmission because viral load is very high. Most people do not know they have HIV infection. These are mathematical modeling data from our SEARCH-10 study showing that if we did not diagnose acute infection on the far right versus we can diagnose acute infection, there's behavioral change, there's viral load reduction with early treatment, we have the potential to reduce transmission by 89%. So by sequencing the virus at the beginning, which we call transmitted founder virus, we have an opportunity to understand the transmission network in our Bangkok MSM community. And so here, if we have an index person who has acute HIV infection, he can transmit HIV to another person or can transmit HIV to multiple people, and they can also go on and transmit HIV to others. When the sequence of the virus is very similar among this group of people, we call it a cluster, a transmission cluster. So in our participant in SEARCH-10, 429 people who have sequenced data, we found that 14% form 26 clusters with other people in the study. And most of the clusters have 2 members, some have 4 or 5 members, and younger age was associated with being in a cluster. Now, if we look at all the clusters, and you can see here on the y-axis is cluster 1 to cluster 26, and the x-axis is time from the first member of the cluster coming into the study to the last member of the cluster coming into the study. And with questionnaires, interviews, viral load, serology data, we are able to define a potential transmitter, and these are shown in the boxes. And so when partner notification works, like in cluster 1 and cluster 5, we have an opportunity to diagnose the index person and his partner almost at the same time, and then start treatment right away and stop the onward transmission. And I think what was surprising to us was that the time that the first person came into the cluster and the last person in that cluster is on average 12 months. And that is a very long time. And so what we think is happening here is that there are multiple other transmitters outside the cluster that has the same virus being passed on to one another very fast before the virus mutates. So what we see here is that we have a rapidly expanding sexual network. Each network could contain hundreds of people. And so this will not be able to be stopped unless people have HIV testing, use PrEP and PEP, and then if infected, get treated right away. And partner notification also needs to be improved. So with multiple exposures to different subtypes, we now see that 1 in 8 people in our cohort in Thailand have virus that is different to the predominant strain in Thailand, which is CRF01AE. And we also see new combinations that contain subtypes that are common in South Africa, like C, and subtypes that are common in West Africa, like CRF02AG, in this cohort as well. Having multiple subtypes circulating makes developing antibody and vaccine for prevention even harder. So here, if you look at the cartoon on the left, the antibody are shown in the Y-shaped cartoon. And so the BNAbs, the idea is that they would bind several strains of virus and be able to clear them and block infection. So if in the community there are so many strains of virus, then it's very hard to build a regimen of combination BNAbs that could actually block multiple strains of infection. And this is the same for vaccines, which are generating T-cell response as well as antibody response. And this challenge also extends to treatment when we want to use these immunotherapeutics. Another benefit of looking at transmitted founder virus is that we can see what's happening in terms of primary drug resistance being transmitted in the community. So here, if you see, because this has direct clinical implication. If we see a lot of transmitted drug resistance, then we might need to screen for resistance in someone who's newly infected. So the good news is that we see a stable prevalence of drug resistance. If you look at the most recent years, 2017 to 2018, we see that NNRTI resistance is seen in 3.4%. So this is below the 10% that WHO recommends to consider screening in a newly diagnosed person. Another benefit of learning from acute HIV infection research is how to diagnose people with low viral load. And there has been concerns whether people with low viral load who are antibody negative actually have HIV. And so here we have 80 people in the cohort whose first viral load was below 5,000 copies and as low as 29 copies per mil. And you can see that between their screening and their enrollment into the study, which is 2 days, the viral load is rising and it's clearly detected. And so we see 0 false positive in people who have low viral load. And these findings have been confirmed in other settings as well, such as in South Africa and East Africa. Another challenging diagnosis is people on PrEP. And so here we have a 39-year-old Thai MSM who started PrEP after exposure during crystal meth. And you can see here that he was screened for 4th generation antigen-antibody combo assay, NAT, and they were all negative. And this was about a week to 3 weeks after being exposed. And so he started PrEP. And at week 4, routine testing showed that the test was inconclusive. And then more testing done showed 3rd generation antibody was ELISA positive, 2nd generation negative, P24 antigen negative. There starts to be some bands on Western blot, and the viral load is now 37,000. So actually, with the sample stored from the initial visit, his viral load was 58. So this case shows 2 things. One is that the viral load that is low was real. He was infected at the time of PrEP initiation. The second is that the seroconversion is delayed. So he's just now starting to seroconvert 6 to 8 weeks after being exposed because of PrEP. Another case who was on both post-exposure prophylaxis and pre-exposure was a 22-year-old Thai MSM who started PEP after an encounter, and then at the week 0, this was just 2 days after exposure, testing was negative, started PEP, 4 weeks, stopped PEP, and then 2 weeks later came in, the testing was negative, then now started PrEP. So because the Thai Red Cross, we do NAT testing, the NAT came back a day or 2 later positive. The viral load on that sample was 32 copies. He had additional workup. All the antibodies were negative, and there's some bands on Western blot. Viral load was very low, 276, and he had subsequent viral load that was detected as well. So this again shows that seroconversion can be delayed. Viral load, low viral load is diagnostic, and that NAT testing helps to identify people earlier, and in this participant, his overall viral burden was extremely low. So I'd like to now shift a little bit and talk about how acute HIV infection research is guiding care of participants with HIV. In our population, where people are just told that they have HIV, the acceptance of immediate ART is very high. So I think this illustrates an important point that what a client needs from a provider is support and guidance. And not every single issue has to be worked out on that day that they're starting ART. But the important thing is that to help them start ART right away, and in the days and months to come, that's the time to talk, to discuss, to monitor, and to continue the support. And in our population, we initially started with efavirenz-based treatment that worked very well. In the last 2 years, we have used dolutegravir-based regimen, which is very well tolerated. And we're monitoring for primary drug resistance in the community. And in our cohort, we do not see any resistance to integrase inhibitor at this time. The viral load decline is rapid and sustained. You can see that by week 12, 94% of people have undetectable viral load, and 97% at 3 years. And the loss to follow-up rate is extremely low. And so I think that we don't have to be so scared of same-day ART, because we have months and years to help participants, to help them to support adherence and that they could continue on the treatment and have a successful treatment. And by giving them treatment very early in acute infection, this helps to reduce the severity and the symptoms of acute retroviral syndrome. Now, CD4-CD8 ratio is a marker of immune dysfunction, and it has been shown to be correlated with poor disease outcome. And here we see that CD4-CD8 ratio normalizes after treatment in acute infection, but does not when treatment is started late. I think one very exciting outcome of acute infection treatment is that it preserves brain function. We know that up to half of people who start treatment in chronic infection have some neurocognitive impairment. This could be executive function, psychomotor speed, fine motor function that can affect daily living. And we see here that using a composite neuropsychological score, and we compare the data to over 500 healthy Thais, we see almost no impairment. 99% of our participants, no matter what stages of acute HIV infection they start treatment, they have normal neurocognitive function. Now, if we're able to diagnose people in seronegative acute infection, we have an opportunity to gain another benefit, which is to help them maintain seronegative status, even after years of having HIV. So here are data showing percent non-reactivity to the 4th generation assay. In PHEBIC1 treated people who were treated within 2-3 weeks of infection, over half maintain seronegative status after 6 months, and now we've followed years after being infected. And so in one of our participants, he shared that although I have HIV, my blood test result is still normal, just like a normal person, and I still continue having my life as normal. So this is a huge social benefit in Thailand, and I'm sure many other settings in the region as well, which having a positive HIV test can limit life options like getting a job. When we ask our participants through interviews, how do they feel and what do they feel about getting treatment so early? And I think some participants said that this was bad news for them to have HIV, but they felt lucky that they knew early. And side effects at the beginning, and I think this is mostly with the efavirenz-based treatment, were difficult, but with time that was manageable. And people view themselves as having a special body because they were treated so early, and they take good care of their body, and they have safer sex. Now, we want to also try to understand when we treat early what is reversible and what is not. And this is important because we want to focus our resources and energy to things that are not reversible, even with the best and early treatment, and then focus trying to change and make that better. So on the left here, you see that the brain does very well with early treatment. And these are also data from brain imaging that we've done hundreds of. CSF viremia, we don't see any. We see immune preservation. The HIV virus is basically frozen in time when treatment is started. It doesn't mutate anymore. On the right, though, we see that we're still not treating tissue infection very well. There's plenty of virus still in the lymphoid tissues, and there's still ongoing immune activation. This may be important in the long run. We're looking at people with HIV living a very long lifespan, and so with decades, perhaps we can improve this aspect. So I'd like to conclude that I hope I've shown you that acute HIV research can guide us in prevention and care. We see an expanding, rapidly forming sexual network in the Bangkok MSM community. We see that acute HIV infection, PrEP, PEP are so important to try to limit new infections, and that same-day ART is very feasible, and it must be done to reduce loss to follow-up and improve people's outcomes. So I'd like to acknowledge our participants. You can see how much they do for science, our investigators, the sponsors for the study, for the ARVs, and many people who help and people whose names are involved really help to give input on this presentation. So thank you very much for your attention.
Thank you very much, Dr. Jintanat. And we have time for questions. So please, anybody with questions, come to the microphone, introduce yourself. Please go ahead.
Hi, I am from Myanmar. So we've been talking about PrEP recently in the region. So you share your experience with the acute infection starting PrEP, and so at that time, in many regions, NAT testing and viral testing is sometimes not possible for the to start a PrEP. So if we can do the symptom screening, like symptom screening of the acute infection, is it really helping, or what are your suggestions for the resource-limited study setting for that?
Thank you very much. So you're saying that in your, maybe don't go yet, in your setting, you're worried about correctly diagnosing HIV at time of PrEP initiation,
yes.
Is that right? Yeah, I think that the most important thing is to do the standard tests that you will do, and if that's negative, then start PrEP. I think that NAT helps in terms of diagnosing people early, but it's not an absolute need to have that before you start PrEP. I think it's more important to start PrEP right away. And I mean, acute, the symptoms help when we see people with symptoms. I think that we have to always be thinking that that could be acute infection, and even if the regular test is negative in people who have symptoms, then that might make you think of doing additional tests like viral load or nucleic acid testing. Nitya is right here, so Nitya, maybe you can say something too, because you're the PrEP expert.
So just to add to what Jintanat mentioned, I mean, I completely agree with that message that please just use what's the best HIV testing algorithm in your setting to rule out acute HIV infection, and then start PrEP in that person who would be at a continuous high risk. There's no perfect testing algorithm for sure. Even with the case that Jintanat presented, with the use of NAT, you will still miss someone. And I have to say that someone is among like almost 5,000 people that we would miss. But if you delay PrEP initiation among certain people, you will get much more people infected. So I just want to echo that message.
Yeah, hi.
Go ahead.
Hi, Jin. Well, excellent talk. I'd like you to help elaborate a little bit on the neonatal infection, which is a kind of another form of acute infection. Do you have any research information on what's the evolution of those who received treatment, right after birth, in terms of immunology recovery or anything is there anything comparable or different from those adults who have acute infection?
Thank you very much. Yes, definitely. I mean, I think the pediatric field was more advanced than the adult field in terms of acute infection, because the phenomenon of seronegativity has been seen in children for many, many years, and now we're just reporting it in adults. So in children, it's just more complicated. The way the infant diagnosis is done, and it should be done that way anyway, because it's done on many, many thousands of children in the country by dried blood spot. If the number of infected cells are very low, then it could be falsely, we could not find the infection. And so there could be a delayed diagnosis. And so it's really, I would say, in general, no matter with children or adults, we have to monitor them long enough to really be sure whether we have diagnosed or excluded infection. And in terms of serology, actually, I'm asking all sorts of people to help me answer questions, but Mark D'Souza is right next to you. He's looked at serology evolution in children who were treated early. And maybe you'd like to say something, Mark.
No, it's just children actually, from the data, the published data, what we found with the Thai data is that they really do stay seronegative for years and years. I mean, not all, but many of them do. And it's also very dependent on the test kit that you use if you see seronegativity or not in infants, as you well know. So that's it.
Achamprapan.
Okay, yeah, excellent lecture, simple and easy to understand. Okay, I have not heard your talk for a couple of years now, so still excellent here. My question to you is, with the data that you have shown, so would you advise any policy makers, with whatever countries, for certain high-risk populations like MSM or maybe IDU, nucleic acid testing for the most sensitive fourth generation negative samples should be done either pool or individually in order to better control the epidemics?
It's hard to, I think that it's very costly, and so it would depend on the incidence in that population. I think if the incidence is high enough, it might be worth to do pool nucleic acid testing to identify people in acute infection. But, you know, I'm not sure how cost effective it is, so that's why I'm having a little hard time answering. But I think that it's more important, though, to screen, and if antibody negative, to start PrEP. Because it doesn't really, if someone is in acute infection, to be on Truvada doesn't really hurt that much. You know, you're really still treating very early, and then as long as a person comes in for regular antibody testing, as we have seen, the seroconversion will occur just a bit later, and then they could switch to treatment. So I'm presenting this to just show, you know, that it's very complicated, but I don't want the fact that people cannot screen for acute infection to be something that they worry about starting PrEP. I think that PrEP should still go ahead.
Yeah, for example, at the Thai Red Cross Anonymous Clinic, 10% of our MSM are HIV positive. So I think, you know, no matter whether or not you have this search study, I think at least Red Cross or Thailand, you know, should invest, you know, NAT testing in this particular population. I think that would be.
And also, but I think, I think that would be great if that could happen. And the other thing is that in cases that are antibody negative but high suspicion, then viral load or NAT should still be covered. So at least in those participants, acute infection could be diagnosed. Oh, okay. I'm glad I didn't see myself up there in such a big, it freaks me out.
If no further questions at this time, we'll move on to the next speaker. Thank you very much, Dr. Jintanat.